In the ICU, we spend so much time stressing over potassium. I mean, we watch that K value like a hawk.
We do, every single day.
But when you look at the actual morbidity data, and frankly, when you look at where people really wipe out in their final exams, it's not potassium that's the silent killer. It's the forgotten ion. It's magnesium.
It is absolutely magnesium. And the irony is, while it's sort of forgotten in daily practice, it is obsessed over by examiners. I can't stress this enough. If you are sitting for the MD anesthesiology exams, particularly with the Gujarat University papers coming up, you cannot treat magnesium, calcium, and phosphorus as afterthoughts.
They're not just footnotes.
No,
Yeah.
They are the big three causing multi-system havoc. They're a favorite for a reason.
Exactly. So welcome back to the deep dive. Today, we're shifting the format a little bit. We aren't just casual observers. We are simulating a high-stakes pre-exam prep session. I'm going to take the role of the final year resident who, thinks he's ready but is probably missing some critical nuance.
And I'll step in as your senior faculty mentor. My job today is to make sure you don't just pass, but that you really crush the viva and write a theory answer that stands out from the pile.
Okay.
We're pulling this directly from the standard text. We're talking Miller, Morgan, Guyton, and of course, O's intensive care. Our mission is to cover the physiology, the clinical features, and specifically the anesthetic management of disorders of magnesium, calcium, and phosphorus.
Perfect. So let's just jump right in with the forgotten ion, magnesium. Why is this the exam favorite? What makes it so special?
Because it touches everything. I mean, think about it. It's not just an electrolyte. It's a drug we actively use. It's an antiarrhythmic. It's a bronchodilator. It's an anticonvulsant.
Anatocolytic.
Anatocolytic, and it's a physiological calcium channel blocker.
Yeah.
So if you get a question on magnesium, the examiner is checking your knowledge of the heart, the brain, and the neuromuscular junction all at once. It's an incredibly efficient way to test a huge chunk of the syllabus.
Okay, so let's get the numbers out of the way because I know I need to quote them in the exam. Total body magnesium is about 24 grams, or around 2,000 MEQ. The normal serum levels are, 1.7 to 2.1 MEQL?
Those numbers are correct, yes. But if you stop there, you've completely missed the most important concept.
Uh-oh.
The most critical sentence you can write in your answer, the one that tells the examiner you actually understand this, is this: serum magnesium is a liar.
A liar, okay? Why? Because it's almost entirely intracellular.
Exactly. Think about the distribution. About 50 to 60% is locked away in bone. Now, this isn't a rapidly available pool. It's a very slow exchange.
Right.
Another 20% or so is in muscle and soft tissue. Less than 1% is floating around in the plasma where we can measure it. So you can have a patient with a normal serum level of, say, 1.8, who is actually profoundly depleted intracellularly.
And this is the whole concept behind the magnesium load test, isn't it?
Yeah.
Where you give a dose and then see how much the kidney actually excretes versus how much it holds on to.
Precisely. That's a very high-level concept to bring up in a Viva. In a person with normal body stores, the kidney will just dump most of an external and exogenous load.
It doesn't need it.
It doesn't need it. But in a depleted patient, the kidney and all the avid tissues will hold onto it for dear life.
Yeah.
It's a functional test of total body stores, not just the snapshot from the serum.
Functionally, I always think of magnesium as the engine oil. It's involved in, over 300 enzymatic reactions?
It is the engine oil. That's a great analogy. It's a cofactor for all ATP production. I mean, no magnesium, no energy currency. It's absolutely vital for DNA and RNA synthesis. But for us, for anesthetists, the money is at the cell membrane. It regulates the sodium-potassium ATPase pump.
Okay.
And crucially, it regulates the calcium channels. This interaction is everything.
Let's drill down into that neuromuscular junction, the NMJ interaction. This is always a Viva question. I always visualize magnesium and calcium as like two people battling to get through the same door.
That's a good visualization. It's essentially a competition. So at the presynaptic nerve terminal, calcium influx is the trigger. It's what causes the vesicles full of acetylcholine to be released into the synapse.
Right.
Magnesium directly competes with calcium for those voltage-gated channels. So if you have a high level of magnesium, it physically blocks calcium entry. No calcium gets in, no acetylcholine gets out. Simple as that.
So it's primarily a presynaptic inhibition.
Primarily, yes, but it's not the whole story. It also decreases the sensitivity of the postsynaptic motor endoplate to whatever acetylcholine does get released. And on top of that, it reduces the excitability of the muscle fiber membrane itself.
Wow. So it's a triple threat to neuromuscular transmission.
It is. This is exactly why a patient on a magnesium infusion for preeclampsia feels like a wet rag. They have profound muscle weakness.
And centrally, in the brain. What's it doing there?
It antagonizes NMDA receptors. It blocks the excitatory neurotransmitter glutamate. That's the mechanism for why it works so well for eclamptic seizures. It's actively raising the seizure threshold in the central nervous system.
Okay, let's move to hypomagnesemia. You flagged this as exam core. In the ICU, this feels like it's absolutely everywhere.
It is. Some studies suggest up to 65% of all ICU patients are hypomagnesemic at some point. The causes usually fall into three big buckets: GI loss, renal loss, and something called internal redistribution.
GI loss seems straightforward enough: diarrhea, malabsorption, things like that.
Yes, and don't forget high output stomas or fistulas. But the one that students often miss, the one that's a great detail to add to an answer, is drug-induced GI loss. Specifically, proton pump inhibitors, PPIs.
Oh, right. I've seen that warning on omeprazole. What's the mechanism there? It's not just causing diarrhea, is it?
No, it's much more elegant physiology. Magnesium absorption in the gut happens via active transport through specific channels called TRPM6 and TRPM7. It turns out that chronic PPI use changes the pH environment in the gut, and this downregulates these channels. You effectively turn off the active transport pump for magnesium.
That is a fantastic detail for a long answer. Okay, what about renal loss?
Loop diuretics are the big offender here. Furosemide, Lasix. It abolishes the electrical gradient in the thick ascending loop of Henlo that's responsible for driving magnesium reabsorption.
So it just gets washed out.
It gets washed out. But the clinical giant in this category is alcoholism.
Alcohol acts as a tubular toxin, right?
Yes, acute alcohol ingestion causes a reversible tubular dysfunction that just dumps magnesium into the urine. Combine that with the fact that chronic alcoholics almost always have poor intake, and you have a recipe for profound depletion. They're a classic case.
Okay, let's talk about the clinical presentation. It mimics hypocalcemia, doesn't it? You get the tremors, tetany, even Schwastek's sign.
It does, but let's focus on the Viva trap. Here's the scenario. You are managing a patient in the ICU. They have persistent hypokalemia. You keep giving potassium runs, IV push after IV push, but the K+ level just will not budge. What's going on?
Ah, that's refractory hypokalemia. And the answer is always, always check the magnesium.
Correct. But why? An MD candidate needs to be able to explain the why. Just saying the words isn't enough.
Is it because the sodium-potassium pump itself needs magnesium as a cofactor to work properly?
That's part of it, yes, but the real issue, the elegant part, is in the kidney. In the distal tubule, potassium secretion is regulated by something called ROMK channels.
Okay.
Normally, intracellular magnesium acts like a plug or a cork in these channels. It sits there and prevents potassium from just leaking out into the urine. If you are magnesium depleted, the cork is gone.
The channel is wide open.
Wide open. Potassium just pours out of the cell and into the urine, completely unchecked. You can give that patient potassium all day long, but until you replace the magnesium and plug that ROMK channel, you're just filling a bucket with a massive hole in the bottom.
That is the kind of mechanical insight that gets you the gold medal. I'll remember that one. What about the cardiac effects?
It's very pro-arrhythmic. It potentiates digitalis toxicity, for one. But the ECG change you absolutely have to know and be able to draw is the prolongation of everything. You get a prolonged PR interval, a widened QRS, and most importantly, a prolonged QT interval.
And the prolonged QT leads to the big one, Torsades de point.
Exactly. The mechanism involves something called early afterdepolarizations, or EADs. Low magnesium destabilizes the membrane potential during repolarization, and this can trigger these EADs. If one of them hits during that vulnerable period of the T-wave, the classic R-on-T phenomenon, you spin into that characteristic polymorphic ventricular tachycardia.
So, management. If I see Torsades on the monitor, I'm pushing magnesium. No hesitation.
1 to 2 grams IV bolus immediately. It stabilizes the membrane even if the patient's serum magnesium happens to be normal. It works acutely as a membrane stabilizer.
Okay. And for routine replacement in the ICU, say for a patient with a level of 1.2 MEQL, what's the plan?
Slow infusion is key. The O's intensive care regimen is a good one to quote. 0.5 millimoles per kilogram over 24 hours. A very common order you'll see is 2 grams over 15 to 20 minutes, then a much slower infusion of maybe 6 grams over the next 6 hours.
Why so slow?
Because if you give it too fast, you overwhelm the kidney's reabsorptive capacity, and it just dumps it straight into the urine. You have to trickle it in to allow for that slow, gradual intracellular uptake.
Got it. Okay, let's flip the coin to hypermagnesemia. This is almost always iatrogenic, right? We cause this.
Almost always, it's one of two stories. Either we are treating preeclampsia with a magnesium sulfate infusion, or someone has given magnesium-containing antacids or laxatives to a patient with renal failure. You have to remember, the kidney is the only way out for magnesium. If your GFR drops below 30 milliliters per minute, you are in big trouble. You can't excrete it.
There's the classic ladder of toxicity regarding the clinical signs. I should know this cold.
Yes, and you must know the sequence. So the therapeutic range we aim for in preeclampsia is about 4 to 7 millieql. That's our target.
Okay.
Once you start to cross 10 millieql or about 5 millimilla, the very first clinical sign appears. The deep tendon reflexes disappear.
And why do the reflexes go first? Before, say, breathing stops?
It goes right back to that NMJ blockade we talked about. The safety factor for the reflex arc is much lower than it is for voluntary muscle contraction or the drive from the respiratory center. So checking the patellar reflex, that hyperreflexia, is your canary in the coal mine. It's the earliest warning sign.
Okay, so first reflexes go. What's next at the ladder?
If you keep going to around 12 to 15 LAQL, you'll start to see respiratory depression. The patient gets weak, shallow breathing.
And
above 15 LAQL, you get complete heart block and eventually cardiac arrest and diastole.
So if I'm in the labor ward and I'm monitoring a patient on a magnesium drip and she loses her knee jerk, my first step is to stop the infusion.
Immediately.
But what if I miss that and she stops breathing? What's the antidote?
Calcium. You give 1 gram of calcium gluconate or calcium chloride intravenously.
And the mechanism here isn't chelation, is it? It's not binding the magnesium.
Correct. This is a crucial point. It is physiological antagonism. You are flooding the external environment with calcium to outcompete the magnesium at those voltage-gated channels we discussed. You're basically forcing the door back open with a flood of calcium ions.
Got it. Okay, that's a really solid review of magnesium. Moving on, let's talk about the prima donna of ions. Calcium.
Calcium is definitely high maintenance. About 99% of it is locked up in the bone, providing structure. But that tiny 1% in the extracellular fluid is so tightly regulated because it controls just about everything. Muscle contraction, coagulation, neurotransmission.
We absolutely need to break down the fractions. This is basic, but it's essential for any exam answer.
Absolutely. So your total calcium in the blood is roughly 8.5 to 10.5 milligdl, but it exists in 3 distinct states. Number 1, the ionized or free fraction. This is about 50%. This is the only part that is biologically active.
Okay, that's the one that matters.
That's the one that matters. Number 2 is protein bound, about 40%. It's mostly bound to albumin. And number 3 is complexed or chelated, about 10%. That's bound to things like citrate, phosphate, or bicarbonate.
And that interaction with albumin leads to the classic correction formula that we all had to memorize.
Right, because if a patient's albumin is low, their total calcium will also drop, but their ionized calcium might be perfectly normal. And you don't treat a low total calcium in a hypoalbuminemic patient without checking the ionized level first.
So the formula is corrected calcium equals measured calcium plus 0.8 times 4 minus the albumin level.
That's the one. But honestly, in modern practice, we should just be measuring the ionized calcium directly. It removes all the guesswork.
Okay, the pH effect. This is something I see people get tripped up on in Vivas constantly.
It's essentially the Bohr effect, but for minerals. Think of it this way. Albumin has negative binding sites on it. Hydrogen ions, H+, and calcium ions, K++, are both positive, so they compete for these same spots.
Right.
In acidosis, you have lots of H+ ions floating around. They hog all the spots on the albumin. Calcium gets kicked off, so your ionized calcium increases.
Okay. And in alkalosis?
In alkalosis, say, from hyperventilation, your H+ level drops. This frees up all those binding sites on albumin. Calcium binds to them avidly. Your ionized calcium drops.
So the anxious patient who's hyperventilating in the pre-op holding area
Starts to get that perioral numbness and tingling, the paresthesia, maybe even carpopedal spasm. Not because their total body calcium has changed one bit, but because the respiratory alkalosis has forced all their active calcium onto albumin, dropping the ionized fraction.
That's a great clinical tie-in. Let's discuss hypocalcemia. Aside from the obvious, like surgical hypoparathyroidism after a thyroidectomy, the big anesthetic cause is massive blood transfusion.
Yes, this is the whole citrate toxicity issue. This is a must-know. Blood products contain sodium citrate as an anticoagulant.
It binds calcium.
It chelates it. It binds it up. Now, a healthy liver metabolizes that citrate into bicarbonate very quickly. But in a massive transfusion scenario, or in a patient with liver failure or in hypothermia, the citrate starts to accumulate. It effectively strips all the ionized calcium from the plasma.
And what's the clinical presentation of that?
It's all about neuromuscular excitability. Low calcium lowers the threshold for nerve depolarization. The nerves become twitchy, you get tetany, laryngospasm, seizures.
And the heart.
Cardiovascularly, you have to remember that calcium is inotrope number 1. Hypocalcemia causes profound hypertension and decreased cardiac contractility. It causes heart failure.
We mentioned the eponyms, Chvostek's, and Trousseau signs. Are they actually useful clinically?
Trousseau's is, yes. Chvostek's sign, where you tap the facial nerve, is positive in about 10 to 25% of normal, healthy people, so it's not very specific. But Trousseau's sign, where you inflate the blood pressure cuff above their systolic pressure for 3 minutes and watch for that classic carpopedal spasm, the accoucheur's hand, that is much more specific for hypocalcemia.
And the ECG change. This is a guarantees question.
It is. Prolonged QT interval. The plateau phase of the cardiac action potential, which is mediated by calcium influx, is prolonged. The repolarization takes longer.
Which puts them at risk for ROMK and arrhythmias, just like low magnesium.
Exactly.
Okay, management of acute hypocalcemia. We have 2 options, calcium chloride and calcium gluconate. What's the real difference? When do I choose one over the other?
It comes down to 2 things, bioavailability and irritation. Calcium chloride provides 3 times more elemental calcium per milliliter than calcium gluconate does. It's much more potent, but it is incredibly sclerosing to veins. It's like pouring acid into a peripheral IV. If you extravasate it, you will cause skin necrosis. It's a disaster.
So what's the rule?
The rule is generally this. In a code situation or a massive flux, like during the reperfusion phase of a liver transplant, you use calcium chloride, but only through a central line. For a routine ward replacement, you always use calcium gluconate through a peripheral line. It's much safer on the veins.
Okay, that's clear. What about hypercalcemia? The mnemonic is stones, bones, groans, and moans.
A classic, and it works. Stones for renal calculi, bones for the bone pain from osteolysis, groans for abdominal pain, pancreatitis, and constipation, and moans for the psychosis, depression, and confusion.
The causes are usually one of 2 things, right? Malignancy or hyperparathyroidism.
Primarily, yes. In an exam, if they ask about malignancy, you should mention PTH-related peptide, or PTHrP. That's the specific mediator in many cases, particularly squamous cell carcinomas. It shows a deeper level of understanding.
The ECG change is the opposite of hypocalcemia, I assume.
It is a shortened QT interval. The plateau phase is rushed because there's so much calcium available. Repolarization happens very quickly.
Management principles for severe hypercalcemia. What's the first step?
These patients are always profoundly dehydrated. Hypercalcemia causes a nephrogenic diabetes insipidus. They just pee out all their water. They can't concentrate their urine. So step 1 is aggressive hydration with normal saline. You have to restore the circulating volume. That's paramount.
And after they're rehydrated?
Step 2, only after the volume is replete, you can use loop diuretics like furosemide. This will block calcium reabsorption in the kidney and promote excretion. The crucial anesthetic point here is never start the Lasix before the saline, or you'll just worsen the dehydration and all the electrolyte abnormalities. You'll make everything worse.
Okay, we've covered the 2 big stars. Now, let's talk about the section that usually gets skipped over, but you insisted we expand on it. Phosphorus.
Phosphorus is the unsung hero. We do not monitor it enough, and it bites us in the ICU all the time. It is literally the backbone of ATP, adenosine triphosphate. No phosphorus, no ATP, no energy, period.
And it's also crucial for oxygen delivery, isn't it? It's part of 2-spherical-3-diphosphoglycerate, 2-12-3-DPG.
Yes, exactly, which controls hemoglobin's affinity for oxygen. So yeah, it's pretty important.
So hyperphosphatemia leads to a state of energy failure.
Catastrophic energy failure. The exam core topic here, the one you have to know inside and out, is refeeding syndrome.
Right.
Let's paint the picture. You have a patient who is chronically malnourished, Maybe a chronic alcoholic, or someone with anorexia nervosa, or even a prisoner of war. They have depleted total body stores of everything, including phosphate, but their serum levels might be hovering around low normal because the body is compensating.
Okay, I'm with you.
Then you admit them to the ICU, and trying to do the right thing, you start aggressive TPN or high-calorie tube feeds.
And that huge glucose load triggers a massive insulin surge.
Exactly. And insulin is an anabolic hormone. It does three things. It drives glucose into cells, it drives potassium into cells, and it drives phosphate into cells because the cells need phosphate to synthesize ATP to metabolize all that glucose.
But because the body's stores were already empty?
The serum phosphate level crashes to near zero. And clinically, everything that requires energy, which is everything, just stops working.
Everything muscle-related fails.
Everything muscle-related fails.
You get rhabdomyolysis and profound debilitating weakness.
This is the key. The diaphragm fails. You have a patient who is awake, alert, but you absolutely cannot wean them from the ventilator because they cannot generate a tidal volume. If you have a failure to wean patient, check the phosphate. It's often the answer.
Wow, and the cardiac muscle.
You get a cardiomyopathy and acute heart failure.
And what about that 2003 DPG link you mentioned?
Well, low phosphate means low 2-3 DPG. This shifts the oxygen dissociation curve hard to the left.
So the hemoglobin holds on to oxygen really tightly.
It won't release it to the tissues, so now you have a patient with diaphragm failure, heart failure, and profound tissue hypoxia, even if their SpO2 on the monitor is reading 100%.
That is an absolute disaster scenario. How do we treat it? Or better yet, prevent it?
Prevention is much better than cure. The rule is start low and go slow with nutritional repletion in these at-risk patients. You must also supplement thiamine before you give glucose. If you do need to replace phosphate, you use IV sodium phosphate or potassium phosphate. But you have to be very careful. Remember the inverse relationship between calcium and phosphate. If you give phosphate too quickly, it will bind with calcium in the blood and precipitate,
causing acute hypocalcemia.
Yes. You can cause acute hypocalcemia and a nasty condition called calciphylaxis. You have to go slow.
Okay, we've done the deep dive into the ions individually. Now part D. Let's integrate all this for the practicing anesthetist. Let's start by revisiting the magnesium and neuromuscular blockers interaction. This feels very high yield.
It is extremely high yield. The key takeaway is that magnesium potentiates both non-depolarizing muscle relaxants like rocuronium and depolarizing ones like succinylcholine.
Okay, so if I have a pre-eclamptic woman on an MgSO4 infusion coming for a C-section under general anesthesia, what are the rules?
Rule 1. Expect the fasciculations you normally see from succinylcholine to be absent or very minimal.
Reduce your dose of rocuronium significantly, maybe by half.
You absolutely must use a nerve stimulator. Don't guess. And rule 4. Expect reversal with neostigmine to be difficult, sluggish, or even incomplete.
Okay. What about local anesthetics? I've seen magnesium added to spinals.
It's a common adjuvant now. When you add intrathecal or epidural magnesium, it prolongs the duration of analgesia. It acts via that NMDA antagonism we discussed, but in the dorsal horn of the spinal cord, modulating pain signals.
Fascinating. Let's talk about the preeclampsia regimen specifically. I know the exams still ask for the names.
They do. You have the Pritchard regimen and the Zuspan regimen. Pritchard is the old school IM regimen. It involves a loading dose that's part 4 and part IM, and then maintenance IM injections every 4 hours. It's very painful and rarely used in well-resourced setups now, but you might still see it mentioned.
And Zuspan?
Zuspan is the all-IV regimen, which is now the standard of care. It's a 4-gram loading dose over about 20 minutes, followed by a continuous infusion of 1 to 2 grams per hour.
The big anesthetic risk here involves the interaction with neuraxial blockade, like a spinal for the C-section.
Yes, this is a critical point. Magnesium itself is a vasodilator. Spinal anesthesia causes a sympathectomy, which also causes profound vasodilation. And on top of that, preeclamptic patients are often volume contracted, they're dry, despite being edematous.
A perfect storm for hypotension.
A perfect storm. If you pop a spinal into a woman on magnesium, the drop in blood pressure can be precipitous and severe. You need to be ready with fluids, used judiciously, and have your vasopressors like phenylephrine drawn up and ready to go.
Another specific scenario. Pheochromocytoma surgery.
Yes, the James protocol. This is a beautiful application of physiology. Magnesium directly inhibits catecholamine release from the adrenal medulla. It's a fantastic hemodynamic stabilizer to use during tumor handling. It prevents those massive hypertensive surges when the surgeon is manipulating the tumor.
I want to run through some of these common exam questions in Viva traps. The places where candidates just throw away easy marks. Trap number 1. The tourniquet effect.
A classic rookie mistake. You put a tourniquet on to draw blood. The patient has difficult veins, so you leave it on for a minute or two while you're trying to get the sample. You finally get it and send it off.
And the lab calls back with a panic value for hypercalcemia.
Exactly. Why? Because that venous stasis causes a local acidosis in the arm. Acidosis displaces calcium from albumin. You've artificially raised the ionized calcium just in that sample of blood. The tip is simple. Always take calcium samples from a free-flowing vein without a tourniquet if you can, or at least release it immediately once the needle is in.
Okay, trap number 2. The pseudo-hypocalcemia after an MRI with contrast. I've heard of this.
Yes. The gadolinium-based contrast agents can interfere with the colorimetric assay for calcium in the lab, showing a falsely low result. So if a patient just came from an MRI and the lab reports a calcium of 6.0, but the patient have absolutely no symptoms, check their recent imaging history before you start pushing calcium.
Trap number 3. We discussed this, but it really bears repeating. The citrate trap in massive transfusion.
In a massive transfusion protocol, do not wait for the lab to call you and tell you the ionized calcium is low. By the time that result comes back, the patient is already profoundly hypotensive. You have to be proactive. Watch the ECG. If you see the QT interval start to lengthen, give calcium. Watch the arterial line tracing. If the contractility looks poor, give calcium.
Treat the patient, not the number that's an hour old.
Precisely.
Finally, let's talk about structure. This is huge for the written paper. If I get a 20-mark long question on, say, magnesium physiology and its anesthetic implications, how do I structure it to get 15+ marks?
The examiners want to see a clear, logical scaffold. You build the answer brick by brick.
Define the normal values, daily requirements, and its role.
Discuss distribution, the intracellular versus extracellular concept, and its regulation, focusing on renal handling.
List the key functions, enzymatic cofactor, NMJ blockade, membrane stability.
Okay, that's the foundation. Then the disorders.
Yes. Then you have 2 big sections.
Etiology, classify it into renal G, etc. Then clinical features, mentioning the triplet with K and K. Then ECG changes, and finally, management. And you do the same for hypermagnesemia. Etiology, the clinical ladder of symptoms, and management, including the antidote.
And the most important part.
The final section is anesthetic implications. This is the section that gets you the extra marks that separates you from the pack. This is where you discuss the NMB interactions, preeclampsia management, pheochromocytoma, and its role in cardiac protection.
And diagrams. Are they worth the time?
They are not just worth the time, you must draw them. They are essential.
Draw the neuromuscular junction and clearly show MCA blocking the K channel.
Draw some simple ECG strips showing a normal QT versus a prolonged QT in hypocalcemia or Torsades.
Draw a flowchart for the management of severe hypercalcemia, showing fluids first, then Lasix, then other agents. Visuals break up the wall of text and prove to the examiner that you understand the mechanism, not just that you memorized a list.
Okay, we're at the finish line. This has been incredibly helpful. Give me the final bullet point summary, the elevator pitch for the exam.
All right. Here are your absolute must-know takeaways.
Magnesium is the forgotten ion, but it's the most important one for the anesthetist. Remember that serum levels lie. You should assume depletion in critically ill patients, alcoholics, and diuretic users.
Magnesium versus calcium. They're physiological antagonists. Mg blocks CAM entry at the nerve terminal. This is the key to almost all its effects.
Got it.
3. The triplet. Hypomagnesemia causes refractory hypokalemia because of that open ROMK channel, and hypocalcemia by suppressing PTH secretion. You have to correct the magnesium to be able to correct the others.
The toxicity ladder for hypermagnesemia. Loss of reflexes first, then respiratory depression, then cardiac arrest. The antidote is always calcium.
Calcium. It's all about the ionized fraction. Acidosis increases it, alkalosis decreases it, which causes tetany.
Hypocalcemia. Think massive transfusion and citrate. Clinically, watch for a long QT interval.
Phosphorus. Remember it as the energy ion. Refeeding syndrome is the classic exam scenario, and it kills via diaphragm failure and cardiomyopathy. And finally, 8. Management. Always treat the underlying cause and always respect the speed limits for 5E replacement to avoid dangerous side effects like precipitation or cardiac collapse.
That is an incredibly comprehensive review. I honestly feel much better about that looming Viva now.
Good. You have the knowledge. The key in the exam, both written and oral, is to pause, think about the underlying physiology, and then speak or write. Don't just list symptoms, explain the mechanisms. If you can do that, you aren't just a candidate trying to pass. You're demonstrating that you think like a consultant.
Thank you so much, senior faculty. And to our listeners, specifically our Gujarat University candidate, good luck. Go draw those diagrams, review the interactions one more time, and go crush that exam. This has been The Deep Dive.
Good luck. You'll do great.